So, pharmacokinetics, fancy name for how the drug moves throughout the body. And there's really four key phases that are there. The first one is absorption, which is basically limited by disintegration. So how easy the drug is to break down is how quickly it is absorbed. We talk about the term bioavailability being the amount of drug that is ultimately absorbed into the circulation and is available for some kind of action. Once it's absorbed, it then needs to be distributed throughout to where the target organ is. It is then metabolized by the liver and eliminated by the kidney. There is some other elimination through other places, but it's primarily liver metabolized, kidney eliminated. This is just kind of just showing, this is out of the text. You can see how it's absorbed in the stomach, or in small intestine, or large intestine. Usually not the large, but stomach or small. Pulled into the bloodstream, distributed throughout the body, and then finally it's metabolized by the liver, broken back down, and eliminated through the urine or through feces. A lot of this part of the lecture is a lot of terminology stuff, just so we're on the same page. But selectivity talks about the extent to which a drug acts at a specific receptor site, and no drug is completely selective. It can target multiple receptors, and because of that, can have side effects associated with it. So if you look at drug A, drug B, and drug C, the receptor that is there is specific to drug A, and drug B and C would not be able to interact with it. It's basically how drugs work at various receptors. It's called a lock and key receptor theory. And when that binding occurs, something happens in a physiological fashion. Could be that there are channels that are open, so ions are allowed to pass. Calcium channel blocker, for instance, is something that blocks the calcium channel. It does not allow, when that binding occurs, does not allow the calcium to move. Sometimes it's some other biochemical messengers that are activated, and sometimes it's whatever the function of the cell is being either stimulated or being turned off. So different things. But drugs have specific selectivity. So for instance, where we're going to talk about our sympathomimetic beta agonists, they have a selectivity to the beta 2 receptors within the lungs. They also, though, have the ability to trigger beta 1, which is heart rate and blood pressure. So they have as a potential side effect cardiovascular effects, in addition to the desired effect of the bronchodilator. Make sense? Thank you for nodding. A couple other terms that are there. One is racemic, and racemic is something which chemically it's the same compound, but it's just constructed in kind of a different pattern. And we call those different patterns isomers. So a racemic, there's a drug, for instance, one of the drugs that we utilize is called racemic epinephrine. It's like epinephrine, but it's not really like epinephrine. It's kind of a cousin, if you will, or in some cases it's part of a mirrored image that we'll end up seeing. Agonist we talk about as being something that binds to a specific site and initiates a response. So we talk about beta agonists stimulating beta 2 receptor sites, and these agonists will always have an affinity, a desire to want to link up with that receptor. Antagonist is the opposite. It causes the it blocks the activation of that receptor, and this is possibly one of the reasons why a drug's action is less effective, because it's being blocked by another drug. So here's an example of an agonist. You can see the drug binding with the receptor site and an action happening, and an antagonist binds with that site and prevents something else from binding instead. So sometimes, in this case, that antagonist that is there, singular, is blocking that site so the leukotrienes cannot come and cause havoc. instead of having a direct action, it's preventing something else from causing an action to happen. Got the distinction? Affinity talks about the measure to which the drug has the ability to bind with that site. A higher affinity means there's more love for it, means it has a higher desire to want to match up with it. Two other terms that are similar in nature but are definitely different. One is potency, and potency talks about how much of a drug is required to get to a specific response. A more potent drug would require a lower dose to get the same effect. So if I'm looking at, let's say, a bronchodilator and the various bronchodilator drugs that are on the market, we use the index of an FEV1 improvement as saying how good or how potent that drug is. A drug that is more potent will get to the same effect, a rise in FEV1 of 20%, but do it at a smaller dose. Okay? Efficacy talks about the maximum biological effect that you could end up seeing. So here we have an example where I have two drugs, drug A in the red, drug B in the green. Drug A is more potent because it has the same output, but it's doing it at a lower dose as far as being only at 20 milligrams as opposed to 40 milligrams. Okay? So that's potency. Effectiveness talks about, do I get more improvement? A more effective drug will have a greater improvement. So in this case, C is not only more potent because it doesn't require as much, it also generates a higher output or a higher response that is there. And this is looking at peak flow. Drug C has a smaller dose required, so when I think of it, the pill would be smaller, and it generates a better effect, a better outcome. Okay? So we would say that drug C is more potent and more effective. Does that make sense? That sometimes gets a little bit confusing between the two terms. Potent talks about quantity, effectiveness talks about output. Okay, tolerance. Tolerance is basically where you're taking more and more of the drug and you're getting less and less effect. Okay, a lot of times nasal sprays for allergies can get that way. You build up a tolerance to it. You lose effectiveness. It just doesn't. The same dose doesn't do what it used to do. Tachyphylaxis is a specific type of tolerance where it is a rapid decrease in response. And this is something where the tachy should give you the clue that it's rapidly occurring. So very quickly you develop an inability for the drug to work after an initial dose. Sometimes there's desensitization where the tissue responsiveness can occur with drug exposure. You lose tissue responsiveness. And a placebo, as you should probably know, is an inactive substance that is given. Often when we're doing experimental trials, they'll give one dose of placebo versus a dose of drug, so we can evaluate whether or not there's any improvement.
So tolerance, I mean, alcohol is a drug, and in that condition, less and less, you need more and more of that substance to, if you have that, you need more and more alcohol to bring the same effect.
Okay, so the alcohol doesn't have the effectiveness it once did.
X volume, right.
Okay. Yeah. Couple other terms that are similar in nature that you need to distinguish. Additive is one where we're talking about the effect of one drug plus the effect of another drug combined together. The effect is you don't see necessarily a greater improvement. You can give two drugs together and have an additive effect. They both have benefits. Synergism, on the other hand, is the joint effect of two drugs where given together, they actually have a higher output than either one of them would have had individually. So I got the numeric examples there. Additive is just 1 plus 1 is equal to 2. Sounds good to me. Synergism, on the other hand, is 1 plus 1 is equal to 3. Now, albuterol would have some output. Ipratropium bromide would have some output. Put them together, and it's bigger than the sum that they would have if you just gave them individually. Does that make sense? They kind of work hand in hand to actually get a better improvement. That's one of the reasons that we often will combine two drugs together in a formulary so that we're getting the peak effect in the process. Potentiation, on the other hand, is, yes, Alyssa?
How do you figure out if it's an additive or if it's synergism? Like if drugs will...
This is just during the testing of the combination together, they saw the improvement being higher. You wouldn't know necessarily just by going, oh, these two drugs, they must be synergistic. But if the studies that were done on that showed that they had a bigger effect than you would expect to see, then we can say it's synergistic. Potentiation. One drug has no effect but increases the response of the other one. So it, in and of itself, the second drug isn't really doing anything other than potentiating the effect of the first one. So it's, I can't even think of a good analogy.
Catalyst.
Almost like a catalyst, yeah. But 1 plus 0 is equal to 2. You get an idea there. Why do I have these here? I have no idea.
Ours you had circled.
Yeah, combined effect, potentiation.
Oh, there we go. There we go. Or it can be actually worsened. So there's effects other drugs can have on any given drug. Which drug this is? Oh, terbutaline. There we go. So we combined, it potentiated, worsened. So. Half-life talks about the time it takes to get half the drug eliminated from the body. So after it's been absorbed and distributed, how long does it take for half of it to get out of your system? We call that the half-life. Some drugs have an extremely long half-life. Some drugs have a half-life of only a few seconds. So administering it can be tricky, especially when you have things like liver disease or kidney disease. So it's not being metabolized at the proper rate, and it's not being eliminated at the proper rate. The half-life can actually become tremendously extended. Yeah.
But that would be the main reason of why that's relevant. Why would we want to know the half-life?
Well, let me give you an example. There is a drug that is given for a cardiac dysrhythmia called adenosine. Adenosine has a half-life of about 6 seconds. Well, I better put it into an IV that's pretty close to the heart, because by the time it's being infused,
It's gone.
it's already deteriorated.
Metabolized.
Yeah.
Yeah.
On the other hand, a drug like I'm trying to think of theophylline. Yeah, I drew a blank. Theophylline is a medication that we give for bronchodilator, or it has bronchodilating effects, as we'll find. But in the case of somebody who has liver disease or heart disease, that drug can actually not, the half-life can be so long that can actually have toxic side effects. So that's kind of why those two, why that fact is important to keep in mind. Loading dose and maintenance dose. Loading dose is basically where you give a higher dose initially to build up the blood level, and then maintenance is what is maintained over time. So graphically, you may have a situation, especially with antibiotics that are administered via IV, where you have what are called peaks and troughs. The peak is after you first administer it, the concentration of bloodstream is higher, and then gradually it starts dripping back or falling back down as it's absorbed and metabolized and excreted. And you reach a trough, at which time you give another dose again. So the object is to try and maintain some degree of constant level within the bloodstream, recognizing that there's this up and down vacillation that occurs as the drug is metabolized. You'll also see this, anybody ever been on oral steroids? Where you get the little pack, yeah, prednisone. So you get a big dose initially and then gradually we taper it off. Same idea there. Oh, the reason for that tapering is a little bit different. But. Side effect is anything that we don't want to happen when the drug is administered. We also call these adverse drug reactions, or ADRs, that need to be reported. These are not allergic reactions, so it's not something where I'm allergic to Vicodin. Whenever I take Vicodin, I itch like crazy. That's an allergy. That's not something that is an adverse reaction. Adverse reaction would be me going into cardiac arrest. That'd be a bad thing that would happen. Cumulation talks about the fact that some drugs have a rate of inactivation or removal that is slower than the rate of administration. So you could have potential of having a higher level on board than you would want to have. An emetic is a substance that induces vomiting. We used to recommend syrup of ipecac for a lot of poisonings. Now the thought is that the stimulation of vomiting is probably not the best idea. What is used in the case of many drug overdoses is a substance called activated charcoal, which literally they infuse into the stomach, and the activated charcoal absorbs the medication that was overdosed on.
And then it passes through.
And then passes orally vomited back up. It's ugly either way. Teratogenicity talks about how what the drug's effect is on a pregnant fetus. Or pregnant fetus, that'd be the wrong way to think of it, wouldn't it? On a fetus, and a woman who's pregnant. How's that? If the fetus was pregnant, boy, somebody's got some explaining to do.
What kind of drugs did you have it to do?
Yeah, exactly. And then systemic effect versus local effect. Systemic effect is what happens throughout the body. Local effect is what happens to a specific target organ. The drugs we administer typically are a local effect because they're acting on the lungs themselves, on the tracheobronchial tree, or in theory even the alveolar structures. On the other hand, you can give that same medication in the systemic fashion, but you get its effect felt throughout the body. So ideally, you want to have a local effect. Another example of a local effect would be a local anesthesia that you get and make your jaw talk really funny. All right, therapeutic index is basically the LD50 divided by the ED50. So let me explain what the hell that means. LD50 is basically the dose at which 50% of the test animals died. How big of a dose do you need to have until 50% of the population dies? Effective dose is the dose at which 50% of the animals have a benefit improvement. So the lethal dose divided by the effective dose will give us an idea of how good, if you want to think of it that way, or how safe the drug is. You ideally want to have a drug that has a very high effective dose. I'm sorry, the other way around. Want a very low effective dose, but a very high lethal dose. You want the difference between them to be wide. Yeah. The higher the therapeutic index, so that means the higher the numerator compared to the denominator, the safer the drug. So big numerator, small denominator, good idea. We want it to be effective at a very low dose, but be lethal at a very high dose. Okay? And lower therapeutic indexes then, meaning that there's a smaller difference between an effective dose and a lethal dose, is a bad thing, and you have higher incidences of toxicity. And you can see there's some drugs that are very commonly administered. Theophylline we talked about being a bronchodilator. Warfarin being Coumadin, which is a blood thinner. It's an anti-clotting agent. Lidocaine is a topical anesthetic, but it's also a drug which is used for controlling cardiac dysrhythmias, and digitalis is used as a drug to increase contractility of the left ventricle. They all have very low therapeutic indexes. You see the lethal dose there, 400 milligrams, effective dose 200. Therapeutic index of 2 is
So you
playing
gotta be
with fire.
careful.
Got to be careful with them. That's right. So just some of the safety things, and when we get to the summer, we'll talk about what the clinical sites expect out of you, and really it's just being safe. That's the biggest thing. Always checking the patient's chart, patient's name band, looking for two ways to identify them, making sure you're administering the right drug. One of the things that you'll see as we go through this is the common application now is to use unit dose, where everything is in a prepackaged plastic, I want to say vial, but a container. The problem is they all look the same. And when you get really old and your vision gets really bad, it's really hard to tell the difference between a Zopanex and a Atrovent. So you got to pay close attention to it in the process, because they're not. Whoever created this didn't do a really good job. And there's no label on it; it's all plastic. Anyone to look for expiration dates, obviously. Many bronchodilators specifically change colors when they're exposed to sunlight over long periods of time. So if you're noticing a color change, it's a sign that the medication probably is no good. You're going to know the medication dosages that are safe and what the normal prescribed dosages should be. You know, by washing hands. Nothing to do there. And, you know, obviously if there's a patient's had an adverse reaction to a drug at one point in time, it should be documented, and that means that you need to go back through the prior notes to see what has gone on. We use the value of 20 beats per minute as a sign that the drug has had an adverse reaction, and at that point the therapy should be stopped. The nurse notified, the physician notified, and in case of you being the student therapist, you would notify your clinical instructor or a preceptor, and obviously stay with the patient. Don't leave them and walk away. And make sure they're safe. Yeah, don't run home. Document all the findings in the process. This is old because we don't use charts anymore. It's all electronic medical record typically now, so you can ignore this. Yeah. Many errors in documentation should be reduced. Well, we would hope so, you know, but it's not entirely the case in the process. We know about the hand washing. I'm not going to go anything there, but there's kind of the process. Stop the treatment, notify the patient, stay with the patient and notify the nurse, and when they're out of danger, contact your clinical instructor and document and notify the physician. Okay. And if there's any changes that are in the orders, that should be passed along at shift change so that the following person. And there's, if you come across an improper order, for you guys as students, it's pretty easy. You just, you know, get a hold of your preceptor and say, I don't think that this amount of albuterol is a correct amount. And remember, July 1st will be occurring while you'll be in clinical environment. And you know what happens on July 1st, right?
And all the newbies come in.
All the new residents come in that have, you know, they were in medical school last week and now they're on their own. And, you know what they call it, the little person who graduates last in their medical school class? Doctor. So, as a therapist, what you would end up doing is there is a chain of command that is there. There's a, especially when you're dealing with resident physicians, there's usually somebody who's senior to them who is on also. So if you're coming across a resident that has got a bozo order, and believe me, I had one of them that wanted me to deliver, how the hell did he say it? 18 15% oxygen with a nasal cannula. You can't. What kind of idiot are you? So I kind of explained it to him, it's 21% in the air, dude. You can't go any lower than that. I forget what his logic was. It was something goofy. So I said, let me talk to your senior. So again, there's somebody higher than that. When you're talking about a staff physician, you have, as an employee, if you don't feel something is safe to do, don't do it. Contact your supervisor, contact your manager, and ultimately contact your medical director. Your medical director is a physician also. In most cases, the two physicians will have a talking to, as far as that is concerned. So there's a hierarchy is what I'm trying to get at. That is there. Safety, safety, whatever. Okay. Let me then move on to Module B.
I have a question.
Yes.
About the tolerance level, is there a certain amount that you start off with, but if they find out that if you see the patient is
Yeah,
not reacting,
there's a recommended dose for every drug that we're going to encounter. That what the
not doing the effect, do you raise it?
then we say that the patient has developed a tolerance to that drug and they probably need to go to some alternative drug.
Because like in the surgery center, some people feel no effect of the first Versed or whatever, you know what I'm saying? So they almost like they gotta give a second one in
Yeah.
order for them.
Yeah, they have a higher tolerance to it.
So there is a spot that you start off with.
Oh yeah, yeah. But many drugs just take a little bit more to have a desired effect on a given patient. I think one of the fascinating things that is going to happen in your lifetime is that we are going to be able to create drugs that are specific to specific genomes within people. There are certain asthmatics, for instance, who have a wonderful response to a drug like Singulair, a leukotriene inhibitor. 60% of the asthmatics have no effect on it. Why? Both have asthma. Well, there's different genomes of asthma that are present, so there's different variations of it. And ideally what we want to be able to do is target drugs for specific groups. That's going to be there someday. Go ahead, Erica.
I was wondering about the treatment. So at the hospital, I'll see them like bebop from room to room, put a treatment, I walk away, do a treatment. Should you
Don't go
stay
there.
with that patient the whole time if you put them on the treatment, or so that?
We'll continue on. All right, let's talk about I'm going to go through the metric and the dosage calculations, kind of some stuff we've had previously, but just want to bring us back on track. And we'll save, I think, the autonomic nervous system for next time. So this is going to be talking about that weight, volume, the universal equation, all that kind of stuff. And then we'll talk about neurotransmitters next time. But let's go ahead and watch a video.
Rick's video series.
I figure 75% to you, and 25% divided between the five of us. Gina, Crowbar, myself, Tom, and the Vega. That makes 5% for each one. Billy, you're cheating yourself. If it's 25% divided among the five of you, that's 14% apiece. Oh, no, listen, Tom. I wouldn't cheat you. You know I wouldn't. No, look here. I'll show you.
All right, we should be familiar with the metric system. I just want to review as far as the different, some of these we skipped over. We didn't do hecto. We didn't do deci. We did centi, milli, micro, nano. So you should be familiar with them. And we know how to do some conversions. So patient voids 3.2 liters of urine in a day. What's the average urine output in milliliters per hour? Well, I can go ahead and set it up to change liters to milliliters, first of all, by setting it up in that fashion. And then converting days to hours, you can find out that it's 133 milliliters per hour. So simple unit conversions that we went with in the process. Crossing off the days. Remember, back solute is the liquid or solid that is dissolved in another liquid. The solvent is what it's dissolved into. Solute would be the vodka. Solvent would be the orange juice. And the process then creates a solution where it's two or more substances mixed together. We know how to do the, using a proportion. If we have a dose on hand and a desired dose, we can go ahead and solve for that. That mechanism that we end up using, or more commonly we would probably use the universal equation, but I'll get to that in a slide or so. Some solutions are percentage solutions where that 20% means there's 20 grams in 100 milliliters, or 1 gram in 5 milliliters. A ratio solution of 1 to 200 means there's 1 gram in 200 milliliters. So that's the way we would end up writing that. Sometimes, however it is expressed. So how many milligrams of active ingredient are in 4 milliliters of a 1 to 200 albuterol? Setting it up, a 1 to 200 means that it's a 0.5% solution. 1 divided by 200 times 100%. 0.5% means it's 0.5 grams in 100 milliliters, or 500 milligrams in 100 milliliters, or 5 milligrams per milliliter. So if I want to know how many milligrams 4 milliliters contains, I would go ahead and set it up in that fashion and solve for X, and you end up with 20 milligrams. Okay? So I would feel comfortable giving you a problem of this nature. Just like 10, 60. The easy way, on the other hand, is the universal equation. Number of milliliters times number of the percent times 10 is the number of milligrams. And solving it that way, you come up with the same exact answer. Dubois nomogram, again, you should be familiar with as far as being able to determine the body surface area, because some medications require that. Height 72 inches, weight 190. We draw a line and find out that our BSA is 2.1. Did you ever see this?
Yeah.
This is over the Grand Canyon. There is a limited. I forget how many people it is.
You can't have any cameras or
Yeah.
phones or anything that can drop because it's a glass bottom.
Yeah.
Oh. Glass bottom too?
Glass floor. I'm thinking no. Okay, let me stop there. And